My name's Lisa Kane. I'm a professor at the University of Michigan School of Nursing, Department of OBGYN, and the Department of Women's and Gender Studies. I'm also past president of the American College of Nurse Midwives. My topic with you today is the United States midwifery workforce challenges. I'm going to speak about opportunities to address education, varied credentials, and the intersections that occur when there's a pandemic and racial inequalities within our country. I'm going to begin by focusing on the fact that in the United States, we have what one might refer to as a broken maternity care system. As you can see from this diagram, we have high rates of maternal mortality compared to other countries of similar resources and countries that spend much less on their healthcare services. And yet, when we look at the United States, we have a death rate of 26.4 that's been increasing over the last 15 years, as opposed to decreasing, which has been the case in all other countries. This is an exemplar of one component of our broken maternity care system. But in addition to rising maternal mortality rates, we also have abhorrent health disparities. African American women in the United States are 3 to 4 times more likely to die of pregnancy complications than white women. And these health disparities persist regardless of education or other health conditions. Both of these taken together cry out for a need for expanded and improved maternity care systems. Look at the availability of midwives throughout the country. We see what are often referred to as many maternity care deserts, where there's no maternity care providers in the area. In this map, when you look at the number of certified nurse midwives per 100,000 population, we see that over half of the counties have no nurse midwife available to them. When we compare that to what's available for obstetrician gynecologists per 100,000 population, we see that, again, almost half of the counties don't have any available obstetrician gynecologists for healthcare services. Taken together, we see, again, between midwives and OBGYN physicians, a number of areas of the country where we're woefully underserved for maternity and women's health care providers. In fact, about 40% of our counties don't have a midwife or obstetrician available. The U.S. is facing a maternity health care provider shortage, and certified nurse midwives and certified midwives are also in short supply when we look at the numbers that are educated compared to the numbers of OBGYN physicians that are educated, and yet we still can't provide services throughout the country. So let me step back and take a minute to talk about midwifery in the United States. A unique feature of the United States is that we have varied national credentials for certified nurse midwives, certified professional midwives, and certified midwives. To just give you a flavor of the variation, certified nurse midwives education is founded first as a nurse and then secondarily as a midwife. They have national certification from the American Midwifery Certification Board, and they also are graduates of advanced degrees with a master's degree or a doctor of nursing practice. They attend nationally accredited programs, and nurse midwives can practice in all 50 states. Most of their clinical education is predominantly in the hospital setting, but it may include some community birth experiences. When we look at the national workforce, there's approximately 13,000 certified nurse midwives available across the country. An additional credential is the certified professional midwife. The certified professional midwife is a national certification from the North American Registry of Midwives. There's varied pathways to become certified, including graduation from schools, degree-based programs, as well as an individual portfolio option, which includes apprenticeship for clinical and demonstration of competencies according to the requirements for NARM certification. The CPM credential is not linked to a graduate degree or being a registered nurse. National accreditation for education programs is available, and about half the graduates that are CPMs or who take certification exams as CPMs have graduated from a MEAC accredited education program. CPMs are able to practice in 34 of the 50 states in the United States, and their workforce is about approximately 3,000 individuals. A third credential is the certified midwife. The certified midwife is not founded on an education as a nurse, but it does require graduate education. People who are a certified midwife attend nationally accredited programs accredited by the same organization that credentials certified nurse midwife education programs. CM graduates also take the same certification exam as certified nurse midwives. And they're often educated side by side in schools of nursing with certified nurse midwives. The challenge with a certified midwife credential is that they're only able to practice in 6 states and their workforce is just over 100. So while you've seen rapid growth in the certified professional midwife credential being recognized in 34 states, the CM credential lags behind, even though it mirrors the certified nurse midwife with the exception of being grounded in nursing. Instead, it's an education in midwifery and the health sciences necessary to support that midwifery degree. So we have a little bit of an alphabet soup in the United States, which can lead to confusion by consumers, policy organization, and accrediting organizations. At the same time, the good news is we've seen an expansion in the overall workforce available by midwives of all 3 credentials. What I want to speak to, though, is how trends in midwifery education are shaping up and where there's opportunities to look at expansion of the midwifery workforce. What we know is the U.S. is facing a maternity health care provider shortage, as I talked about, and we need to think about ways to expand or scale up that workforce if we're going to address the workforce shortage. Certified midwives and certified nurse midwives are educated in usually schools of nursing, but they're all in graduate degrees. There's currently 38 programs in the United States. This number has remained relatively stable with some new programs starting, but other smaller programs closing. This is from a peak number of 50 education programs in the United States back in the 1990s, but we've since seen the numbers dwindle. But we've also seen a number of graduates expand. How has this been possible? Well, primarily through the use of alternative education approaches. We have some programs now that are graduating over half of the graduates annually, but they're able to do so by having large programs that rely on distance models of education, where the students are able to stay in their hometown areas, complete their education at a distance, go to central spaces or campuses in order to confirm their skills, and then they go back to their communities and complete their clinical education with preceptors. This expanded program model has been very successful in leading to increased numbers of graduates over time. So much so that we're able to have a greater capacity for new midwifery student enrollment. Over the last 5 years, we've seen an increase of 19% growth in the number of new students. But this is in contrast to being in a country where there's almost 4 million births annually. So we're woefully unprepared with our midwifery workforce when you think of the population available that could use their services. When we look at the trends over time of the education of midwives compared to the education of OBGYN residents, what we see is that the residents and the numbers educated has been relatively stagnant over the last 30 years. And yet the midwifery workforce, while it's been increasing, is still only about a third that it's of what the OBGYN residents are. So taken together, we see an opportunity to really grow the midwifery workforce to address the provider shortages while we maintain the physician workforce to serve the high-risk population. So we don't have an obstetrical gynecologist workforce shortage. We have a maternity care provider workforce shortage that could be addressed with midwives. When we compare that to the numbers available of certified professional midwives, we see that there's expanded numbers. And when you think about the earlier models that I showed where we have a maldistribution of the availability of providers, we see some of the same maldistribution of certified professional midwives as well. Take that together with where they have recognition for their licensure and ability to practice, it mirrors the numbers and availability of those providers in the different states. From this, the takeaway is that obviously, if you have licensure and recognition in a state, you're more likely to be in practice there. But it also shows us that in some states, certified professional midwives or direct entry midwives are forced to practice in a model where they don't have an integrated approach to the healthcare system, and they're left to fend for themselves in many ways without the resources and supports of the healthcare system because of a lack of recognition of their licensure. When we look at the total number of midwife-attended births in the last several years, what we see is that while we're noting a growth in the number of births attended, it's still woefully low compared to the healthy population that midwives could generally serve. Overall, just over 10% of the births in the United States are attended by midwives. Of those, approximately 9.4% are attended by certified nurse midwives or certified midwives, and only 1.2% are attended by certified professional midwives. But this also aligns with the location of birth, with 1.2% of the births in the United States, just over that being home births or birth center births outside of the hospital setting, which are predominantly attended by certified professional midwives. And the hospital births are predominantly attended by certified nurse midwives and certified midwives, with very few certified professional midwives having hospital recognition. And taken together, it still only adds up to just under 14% of all vaginal births being attended by midwives in the United States. Certainly more opportunity to think about expansion of these numbers. Taken together, I would make the argument that our current U.S. maternity care workforce structure is broken. We have providers trained at a high number who are really prepared to treat high-risk populations. And we have a much smaller number of providers being trained to take care of predominantly healthy people. And yet, when you look at the distribution of what's needed, we have many more people who need healthy, low-risk services compared to those who need high-risk services. So our U.S. maternity care system workforce is upside down relative to what population needs really are. So what can be done to increase the supply of midwives educated in the United States? Well, instead of arguing for changes or expansion of midwifery education, I'm first going to address the issue of opportunities to change medical education. If we look at how we could revise medical school rotations, one would argue that the majority of people in medical school do not go into obstetrics and gynecology as their professional area. And those that do predominantly go into specialty areas. So only a small number actually provide regular OBGYN services. By contrast, medical students could get exposure to obstetrics through other mechanisms than direct patient care, allowing student midwives the opportunity to have greater clinical experiences instead. The lack of clinical experience is the primary rate-limiting factor for the growth of both certified nurse midwives, and certified professional midwives. If we change the hospital setting availability of clinical opportunities, we could expand midwifery education in the hospital setting. We could also modify OBGYN residency requirements for those who plan to subspecialize in areas that don't involve attending births, so that student midwives, again, could have more opportunities for clinical experiences. We could also expand collaboration with the American College of Obstetricians and Gynecologists to develop interprofessional educational models that would support. When we look at midwifery pathway opportunities to expand our workforce, we could expand the certified midwife credential and the number of people educated as certified midwives because it's a shorter timeline because it does not require nursing. If we took this approach, we would also need to combine it with legislative advocacy to increase the number of states that recognize the CM credential. We could also expand collaboration across all of the different credentials to share educational resources. This would help us expand the workforce overall and hopefully increase the numbers with less cost. By sharing resources, simulations, and activities, we also would build interprofessional collaboration. We could also look at the expansion of distance and alternative education models to expand class sizes, similar to what's already successfully been done by a number of programs in the United States, which has allowed us to increase the total number of midwifery graduates, even though we've been stagnant in the number of educational programs that we have available. The ultimate goal is to support interprofessional collaboration within all members of the maternity care team and all types of midwives, so that we get the right care at the right time in the right place by the right provider. And also, I would argue, when I say the right place, we look more broadly at where maternity care occurs and consider broader opportunities within the community, and use all the different providers to the full extent of their training and education, and maintain that physicians need to be available for higher risk patient care, but we don't need to expand their numbers to serve a patient population that could best be served by midwives. In closing, what I'd like to address when we think about the current time that we're in with the pandemic is that what it really did in the United States was expose even more so our broken maternity care system. Health disparities were rampant. The impact of COVID on Black and Brown families was much greater, and the health disparities were increased. We also saw hospital environments that were tailored for the care of the very sick having to figure out how to accommodate and address the normal, healthy, physiologic experience of childbirth. So we saw more families considering the home compared to the hospital, and yet not having the workforce available of midwives who could serve them in the community setting. So it really shows us the need to realign, readdress, and be better prepared to serve people in the right place that they need to have, so that we can ideally develop more midwives to promote healthy beginnings to healthy families. Thank you for the opportunity to have this time with you.